Hello, can you all hear me?
Yes, Prof.
Yes, Prof.
Alright, so can you see my screen?
Yes.
Okay, good. So we should start. Alright, so first of all, thank you. Welcome to this morning teaching. So it's a combination of year 4 and year 5. So for year 5, I guess this is for revision. And for year 4, maybe this is your first encounter this topic. I'm not sure whether you have teaching with your supervisor or not. Alright, but this is important topic that you need to know when you come to orthopedic. So measurement of limb-length discrepancy. You can stop me at any time if you want to ask me, okay? Is it okay? Alright.
Okay, Prof.
Okay, so what's important when patient come to you with limb-length discrepancy? First, we start with the history, right? So either is shortening or lengthening. It can be caused by either congenital or acquired. So it may be there from the birth or is acquired later through some other or due to certain causes. So important, you want to know regarding the birth history or the time of onset when the parents start to notice. I'm talking about pediatric. So in adult, of course, patient comes to you following a trauma or history of infection before. Okay, so you may also want to know about the family history because certain condition may be inherited in nature. Okay, I mentioned history of trauma or previous mention. There are long lists of causes, either congenital or acquired. Okay, of course, in congenital one, it's not so common, but you may see once in a while. Okay, but for the acquired one, it's quite common for you, like a trauma following infection, either bone or joint. Okay, certain tumor also. Okay, or certain neuromuscular problem. Okay, in terms of congenital, it can be high deficiency, means not well developed or become like hypertrophy or hemihypertrophy, atrophy or hypertrophy. Okay, or we call a skeletal dysplasia problem with the bone. For example, what you can see in this patient that the leg is, what happened to this leg? Which one you think is abnormal? Right or left? Right side or left side of the lower limb?
Right side.
Right side.
Okay, right side. What happened to the right lower limb? If I ask you to describe this picture, so what do you notice? Okay, anyone? Can you describe the finding? Can anyone? I think somebody try to join me. Wait, let me see. Yes. So, what do you notice here? What do you notice beside? It's open. Okay, I agree with the pathology on the right lower limb. What do you notice here? What are the findings?
Bone enlargement.
Okay, you don't know whether bone or not, but it's hypertrophy, like bigger. You see that the leg is bigger. Okay, what else? And you see the level of the heel, bigger and longer, right? Bigger and longer, right? So if you see the entire body here, if you look closely, what are the abnormalities can you spot from here? I know it's a bit far, but what can you notice from here?
The right abdomen.
Okay. Okay. Okay, what else? If I show you here, here, what is this?
Cafe Auli.
Cafe outlet spot.
Cafe early spot, right? So
Yes.
if like this, what do you call this? This is spot. What about this? Look like a swelling, right? So what is this? It could be plexiform, plexiform. So this is a case of neurofibromatosis, and patient presented to you with hemihypertrophy, in which the affected site is bigger and longer. So the patient may come to you with limb length discrepancy, but in this case, it's not shorter, but it's rather over lengthening. Okay, all right. So in this case, you see this is quite a normal limbs, but over here you see that the limb is short and not well formed. Of course, obviously, the tibia is shorter than the normal side, and then the foot is not well formed. Okay, if you see here, because of course this one patient around 1 year plus, you see the X-ray, you can see this one 2 bone, this one you can see only 1 bone, and then the ankle is not well formed. All right, so this one we call hemimelia. Melia mean is absent. Hemi part of the bone is absent. So when you say fibula hemimelia, part of the fibula is either the entire fibula is gone, or part of the fibula is gone, or it's not well, it's not formed here, it's not developed here. So you can have also tibia hemimelia. It means that there's no tibia, it's just only fibula. So this is a congenital problem. Patient may come to you with significant shortening, depend on the severity. All right. Or in adult, patient may come to you with shortening also, or maybe some deformity, probably following a trauma. So malunion also can present to you with the deformity as well as a shortening. Right. So we have to know if this is a long case, you want to know the proper history. If it's a short case, and then later we see how you should approach clinically. All right. All right. So any questions so far? All right. If not, okay. Now, because the emphasis today is how to do examination of limb length discrepancy. All right. So first of all, if patient come to you in orthopedic, if possible, we would like to examine patient in standing. So if patient able to stand, you must look how the patient standing. Okay. So you must look from in front, you must from the back. Okay, you must look from the side also. Okay, so you see from top to the bottom. What is the point that you are interested to see? Start with the shoulder level. Okay, whether the shoulder level is equal, or you see here is drop. Okay, it's not normal. And then after that, you want to see the spine, whether there is presence of scoliosis or not. If there's a scoliosis, of course, later you need to determine whether this is we call a postural, meaning that because of the position of the lower limb, and then develop secondary scoliosis, or is structural because of the bony problem. And then if you go down, you would like to see any abnormalities to the lumbar crease here. Look at the pelvis, whether the pelvis is equal or tilted. Okay, you see this is what we call PSRS, posterior superior iliac spine. So you see that in this patient, it's not level. One is higher together with that shoulder, and one is lower. Okay, so look at the shoulder drop, look at the either presence of scoliosis or not, the lumbar crease, the asymmetrical or not, look at the pelvic tilt. So you focus on the back. Okay, and then like I mentioned, okay, you see here that there's an abnormal lumbar crease. Okay, you see here the pelvic tilt, one pelvic is dropped lower than this. Okay, and you see how the patient stand. In this case, well, you can see that there's a asymmetrical of the lower limb. Patient stand on both feet, but the pelvic is tilted. Okay, so in this case, you want to see whether patient stand in tiptoeing, or patient stand while flexing the longer leg. Okay, so you have to see patient as a whole, from top to bottom. Start at the shoulder, look at the spine, look at the lumbar crease, see the pelvic position, is it symmetrical or drop, and see how the patient stand. Either patient need to tiptoeing, or patient stand in slightly flexion of the longer leg. Right, it will give you an idea, okay, whether you are dealing with limb length discrepancy or not. Okay. All right. So if patient stand, this is supposed to be the straight line, we call a plumb line. Okay, patient yang ada problem with the scoliosis or limb length discrepancy, this one will be deviate. Okay. So of course, if you see this deviation here, how to determine whether this is scoliosis a structural one or a positional one? We have to ask patient to bend forward. We call Adam test, and whether the scoliosis remain or disappear. If the scoliosis remain on when patient bending rukuk, bending 90 degree, so if the scoliosis disappear, meaning that it's just a postural. It could be because of the pelvic tilt or because of position only. But if you ask patient to bend forward, but the scoliosis is remain, so most probably it's just a structural one. It could be due to the bony problem. Okay. Right. So of course after that, after you see patient on standing, if possible you would like to see the patient gait, how the patient walk. Okay. So either patient walk in antalgic gait, which is a painful and short stance phase, or patient walk with a Trendelenburg gait. Okay, Trendelenburg gait means that I think you can see in the video in any YouTube. The identity of this Trendelenburg gait is the patient have to swing to one side in order to balance and to avoid fall. And Trendelenburg gait indicate weak hip abductor muscle. Okay, or patient may walk with bilateral weakness abductor. They walk with waddling gait. Okay, waddling gait when both sides of the hip is weak abductor, and so they have a bilateral abductor. Bilateral Trendelenburg is a waddling gait, or they walk like a duck. Okay, or patient walk with a short limb gait. Short limb gait means the difference between short limb gait and Trendelenburg gait. Usually there is no swing of the shoulder in short limb gait, whereas in Trendelenburg gait there's a swing of the shoulder to avoid a patient from fall. Okay, so patient with foot drop, you see that patient has high stepping gait. They try to clear the ground. Okay, because of weakness of dorsiflexion. All right, so that's what you would like to observe. Okay, how the patient walks. So you ask patient, okay, can you just walk for me? And you observe, and they give you an idea what are the type of gait, and to determine what are the possible underlying problem. Okay, okay. Some patient, especially with neuromuscular problem, patient may walk with in-towing or out-towing, or sometimes with equinus. Okay, so you would like to see also. Okay, or due to other neurological or neuromuscular problem, like taxate, cesarean, and so on. All right. So after patient walk, you like to examine patient on supine position on the bed. Okay, what we supposed to do first is we would like to see whether just now you can see whether patient standing on flexing the longer leg, or patient stand on tiptoeing of the shorter leg. In this case, once you put patient on supine, you can see this significant, in this case, that significant shortening of this limb. Okay, so how do you know this is shorter or this is over lengthening? Okay, like the first picture I showed you just now, you see that hypertrophy in neurofibromatosis. So in this case, how do you know this is normal or this is abnormal? How do you know whether the right side is normal or the left side is normal, or the left side is abnormal because of over lengthening, like the previous picture? How do you know? Anybody?
Depends on the patient size.
Depend on patient size. What do you mean by that?
According to the type.
Okay, what you can do is you compare, you look relatively all the limbs and compare to the upper limbs. Okay, is the upper limb is almost symmetrical to majority of this, or this one? let's say upper limb is normal, right and left, and you compare whether this is proportionate or not. Okay, let's say this is smaller compared to upper limb, and the other side, this one is proportionate to upper limb. So most likely this one is abnormal. All right. So if I show you again in this case, all right. So if you see here, this lower limb and the upper limb is proportionate, meaning that's almost symmetrical in size. But you compare here is bigger, is not proportionate to this. So most likely this one is normal and this one is abnormal. Okay, that's one of the clue. All right. So you want to see where is the heel level, the level of the heel, is it symmetrical or not? And also, of course, the level of the knee. In this case, the heel is not symmetrical. This one is significantly more proximal. Same thing with this. Okay. So the next step is you need to do the Galeazzi sign. Okay, a Galeazzi sign. Okay. All right. I'm sure that you know how to do a Galeazzi sign. The most important thing is you put the hip and the knee in 90 degree and make sure that the hip is at the same level. Okay, and then where should you observe? Observe at the level of the knee and also at the level of the tibia tuberosity. So whether this is equal or not. Okay. So if I give you these two picture A and picture B, this picture A, the arrow show the level of tibia tuberosity is not at the same level. Okay, the right side is more inferior or lower than the right side. And level B show the arrow that the patella on the left side is higher than the right side. So in this picture, let's indicate the shortening is located on which part of the bone in picture A.
Right side.
Okay, right side. Okay, which one? Tibia or femur?
Femur.
Tibia. Femur.
Tibia. Dia ada dua je, tibia or femur. Dia tak ada humerus kat situ.
Femur.
Femur.
Femur. A
Femur.
is femur. So B is problem at the tibia. Are you
Tibia.
sure?
Tibia.
Are you sure? 100%.
InsyaAllah.
Okay, so if the level of tibial tuberosity is not at the same level, it's been a bit lower, so the problem is at the femoral shortening. Okay, and in B, if the level of patella is not the same, usually the problem is at the tibia. Problem at the tibia. Okay, understand? This is a Galeazzi sign. Okay, or what you can do is you lift up the lower limb and see the level of the patella here. In this case, that indicate that femoral line is shorter or femoral problem, femoral line component. And if you do here, the level of the hip is not in a prone position, they indicate the tibia component. Okay, so this is your observation first before you do a measurement. Okay, so what happened if the Galeazzi is very much different, very much shortening, like in this case? So you see, the tibia tuberosity level also different, the level of patella also different. So where do you think is the pathology? Where do you think is pathology?
Right femur.
Femur, right femur.
Right femur. Okay.
Why do you say it's right femur? Why do you see the right femur? Because this one also is not level. See, here also not, patella also not level, the tibia tuberosity also not level. So I think somebody try to join. Let me see. I need to approve. Okay. Okay. So where is the pathology now? Is it femur or is it tibia?
Both sides.
Yeah, the possibility is both side, both component, both tibia component or femoral component, or the other possibility is the shortening of one of the component is very marked, very significant. Means that let's say it's more than 5 centimeter. Okay, so if more than 5 centimeter, either one bone or this is caused by pathology in both femur and tibia. So you will get that the Galeazzi sign will be significant. All right. So in very much shortening, you may get this one also, or positive Galeazzi like this can be because of problem over the femur as well as a tibia. Okay. So like just now, so if one level is equal, let's say the level of the knee is equal, but the tibia tuberous is not level, so problem maybe only one part of the bone. Okay, so this one basically the Galeazzi sign here is basically for a minimal shortening, let's say less than 2 centimeter. If let's say the shortening more than 5 centimeter, you may get this finding. All right, you may get this both level is not at both bony landmark is not at the same point. Okay, and you see in this patient, you see there's multiple scar here. Okay, multiple scar here over the hip. So this patient having a problem over the hip. So you said there's not a proper hip. You can see really a good head of the femur and the neck, and the femur or what we call the hip is shallow. Okay, so what do you think? What is the most likely underlying problem in this patient? Why this patient have this scar and have this problem? What probably the etiology? And now patient presented to you with very much shortening. Anybody guess?
Malunion.
Malunion. Okay. What else? What other possibility?
Osteogenesis imperfecta.
Osteogenesis imperfecta usually not really involve the joint. They involve the shaft. The or proximal femur, not over the joint usually. What else?
Hip dysplasia.
Okay, hip dysplasia. Okay, possible. What else? What else?
Pertis disease.
Pertis disease. Okay, so this patient most likely having the what we call a neonatal septic arthritis of the hip. Meaning that during the neonatal period, patient developed septic arthritis lead to damage of the physis and also to the cartilage and joint. So patient end up with deformed and underdeveloped with dysplastic hip. So this is quite significant problem in which patient may later end up with significant limb length discrepancy. Okay, malunion, usually the hip will not affected. The problem usually over the femur only. And DDH, usually the hip is normal but not well developed. And of course, in neglected, the hip joint is shallow also lah. Okay. Alright, good. Okay, so now after you do a Galeazzi sign basically is for you to have an idea where is the underlying problem. So now we need to determine, okay, and we need to measure where is the shortening, okay. So now we need to measure, right? So we can measure either using a tape or what else? How else that we can measure the lower limb, especially patient will come to you, you want to determine limb length discrepancy. Why we using a method tape? The other one, clinical. I'm talking about clinical, not radiological. How do you measure the lower limb? Final year? Tak ada jawab. Not sure. So this is your conventional way. You measure using a tape measurement. Okay.
Calculate the apparent length and the true length.
Yeah, of course. No, I mean that the clinical method. Now you use a tape, you measure the apparent length and later you measure the true length. But besides using this tape measurement, how else that you can apa ni, ensure which one is lower, which one is longer, and how much?
Ruler.
What other method?
Ruler.
Blood test.
Like blood test.
Block test kan? Block test. Okay. So what do you understand by block test?
We ask the patient to stand, and then so the best to measure, use the slide blood test. The best to measure the inframalleolate involvement.
So block test is basically you ask patient to stand on the block of something, wood or whatever, okay, until you get the pelvis is level. Okay, this is a block test. So you can measure through this or you measure through this. So later you measure how thick is the block that required for the pelvis to be equal. So we go a bit detail later in later presentation. Okay, are you clear? So we use either tape as conventional or we use a block test for clinical ways to measure the dim line discrepancy. Okay, so which one is more accurate comparing these two methods? Which one you think is more accurate? Which one, the tape measurement or the block test, and why?
Test.
Blood test.
Block functional.
Block is functional. Okay, why is it block is functional?
Because some discrepancy in terms of the length measured in the tape might not be really affecting the patient's clinical status, whereas the block truly like measured how the patients will walk and stand.
Okay, so we leave it first. Later on, we will see. Okay, and then tell us again. All right. So now we want to measure using a tape. So you have to identify the bony landmarks. So our bony landmark, either you measure from xivisternum or umbilicus, your axis, medial knee joint line, medial malleolus, and also greater trochanter for a segmental measurement, right? Okay, so this one you need to know, and you need to identify and get it correctly first. Otherwise, your measurement will be inaccurate. So, of course, umbilicus is fixed point or is a fisternum. Okay, so this is one point, and your axis. You should know, and if we ask you in the exam, how you determine this level is axis or axis. So you should start from your symphysis pubis, go along your ligament, inguinal ligament, until you feel your first bony prominence. So the most important thing is we want a consistent level. Okay. So if the problem, if you don't mark properly, one you may be at the bony prominent, one not at the bony prominent. Later on, you will affect your punya finding. So must be consistent. So you start from superficie, go obliquely until you feel your first bony prominent and make a mark. You must ask permission from the patient to mark the assist. Okay, normal on the normal side or on the affected side. Okay, and then your medial joint line. So how you determine this is your medial joint line? We start from your tibial tuberosity and you go more proximally and go medially. You feel in between these two bones. You put your finger here and you try to flex and extend the joint. You feel that there's a movement there. Okay, and then you mark this is your medial joint line. Okay, and then your medial malleolus. Okay, how do you determine where do you want to mark? Okay, so to be consistent, usually we come from distal and then we move proximally until we feel the bony prominent here. So you don't come from here and you mark. You may mark here, you may mark here. So if you come from here, it become a fixed point. And like I said just now, we want a consistent point or consistent level so that you reduce the error. Okay, so you already mark you have umbilicus, axis, medial joint line, medial malleolus. Now greater trochanter. How you locate your greater trochanter? How do you locate your greater trochanter? Anyone?
Find the lateral condyle of the femur.
Hmm? And then?
So we find the lateral condyle of the femur. We all go along towards the hip, and then we move the leg internal and externally, and find
Okay, so
the
for the patient yang thin, you can locate from the lateral femoral condyle, go laterally, go lateral and proximal until the last bony prominence, and you put your finger there, and you roll the lower lip, and you feel that your finger akan move. So your finger actually at the greater trochanter. What about if patient is obese that you cannot feel, you cannot really appreciate? What are the way that you can locate? Okay, this is the area of the greater trochanter.
Palpate for the femoral pulse, and
Uh-huh.
then go laterally. So that is
Uh-huh.
where the greater trochanter.
What is the anatomical relationship between femoral pulse and greater trochanter?
Based on your teaching, Prof, just let go lateral from the palpation until you feel the prominence.
Based on my teaching, you cannot quote me lah. It must be very yang muktabar punya tu. Okay. So basically, if you see your anatomy, your femoral, what's the basis of femoral pulse? You palpate over the bony prominence, right? So you're the most what we call uh, prominent pulse when you palpate against the hip. Okay, at the center of the hip, you palpate here, and the center of the hip is at the level of greater trochanter here. Okay, your superficial pubis is your greater trochanter. So just now, if you go from distal to proximal, this is your position. So if you locate your femoral pulse, you go distally, and then you can locate this is area of greater trochanter. So you put your finger here, and then you roll the lower limb, so you can feel that the femur will move. So you know this is your area of greater trochanter. Alright. So you locate your axis, you locate your greater trochanter, medial malleolus, medial joint line. So that's the point that you have to mark before you start measure. Alright. Now we want to know where is the level of discrepancy. Is it the leg, the thigh, or supratrochanteric? Especially when we do, or we want to know the true limb length discrepancy, right? But before we do a true length, we should do the apparent length. What are the difference between apparent length and true length measurement? What do apparent length tell you? What do the true length tell you?
Apparent length,
So apparent length basically,
which limb is shortened, and then true is which segment.
not really. Apparent length is basically what is appeared to be seen or what were perceived by the patient. It could be apparent length and true length is the same, or it could be it's just apparent. The reality, the length is equal, but it's appeared to be shorter. Alright, whereas the true length is the true measurement. It could be longer or shorter on the certain part of the bone. Okay, but apparent length it still can be normal length or it appear shorter or longer. Appeared. Oh, so that's what we call apparent. Okay, so we call apparent length because we don't really need to do other maneuver. So apparent length we just measure from either xiphisternum or umbilicus to a medial malleolus without we need to square the pelvis or equal the level of the pelvis. Okay. Whereas when we want to do a true length, we need to make sure that the pelvis is equal first. Only that we do a measurement, and then the level is from axis to your medial malleolus. Okay. Is it clear? Especially for year 4 lah. Is it clear?
Yes.
Oh, alright. Okay. Because I have to ni kan, year 4 and year 5. Year 5 already know this. It's just a revision for them. So if you're not sure, you just can stop me, okay? Okay, so apparent length is discrepancy, or we will report with as a discrepancy or lower length. It could be not a true amount of limb length discrepancy, or it can be true also. That's what we call apparent, and we report as apparent length. We don't report as the let's say we don't report from here to here 120 centimeter. We just report from on the normal side and compared to lowest the abnormal side. We just want to know the discrepancy. Let's say this one is 120, this one, the affected side is 117. So we report as apparent length of 3 centimeter. Okay, so when you measure, so we will ask you, what is the limb length discrepancy? Limb length discrepancy is 3 centimeter, not 120 or not 117. So understand, we are interested with the discrepancy. Okay, so basically the apparent length we need to measure straight away. We don't have to fix the pelvis. Okay, so whatever position of the lower limb, we just measure. Okay, whereas for a true length, we need to square the pelvis. Okay, square the pelvis means we need to make sure that the assist must be at the same level before you start to measure. Okay, this is sometimes I observe in the exam that the candidate, either undergrad or postgraduate, fail to do. Okay, when they measure straight away. After they mark, okay, or the bony landmark like assist, greater trochanter, medial joint line, medial malleolus, and they fail to show to us that they really look for squaring of the pelvis first. Okay, so if you do that, so you are not doing the correct thing for measurement of true or real length discrepancy. Okay. Now, patient may come to you with this pelvis is not square. Okay, the assist end is not square. And now, how? So I said just now, you need to make sure that if you want to do a true length measurement, the pelvis must be square at the same level. So how do you square the pelvis? In this case, for example, okay, one, you see that this leg appeared not normal. One is longer, one is shorter. Okay, and you see, if you do a apparent line, you just measure straight away from umbilicus to medial malleolus, from our left side and our right side, and you measure that. Okay, this patient probably ada limb length discrepancy of 2 centimeter. But once you want to measure a true length, you must make sure that this assist and incision must be square, must be at the same level before you start to measure. So the question is, how do you square the pelvis? So let's say in this case, anybody?
Make the patient lying supine.
Yeah, patient is lying supine now. Patient is lying supine now. Of course, you measure patient in lying supine. We don't measure why patient is standing. Okay. Now you notice why patient lying supine, the pelvis is not square, and now the leg appeared discrepancy. One is longer, one is shorter. So the prerequisite before you do a true length, you must make sure that the pelvis is equal first. Otherwise, your measurement will be inaccurate. So how do you square the pelvis?
We ask the patient to sit first, then in supine position.
You ask patient to sit first and in supine position again. So no, you won't be able to get the square pelvis.
Further adduct the affected limb.
You adduct the affected limb. Okay. So if the patient is small, you can lift the buttock and then you try to maneuver so that until you get the pelvis is square. But sometimes it's difficult. It still remain like that. So what you can do is, okay, so you see that patient, if the patient have adduction, especially adduction deformity of the hip, so the pelvis is tilted like this. Okay, if you try to square, it's a bit difficult. You try to move and you try to ask patient to correct it, also difficult, or you will not manage to get it. So what you need to do is, Okay, you say adduct. So basically you need to cross the leg. Okay, when you cross the leg, okay, and the pelvic will become square. All right, and you need to do this before, and then you make sure that the pelvis is at the same level before you start to measure. So understand? Okay. But
Prof,
if the patient come to you, yes.
maksudnya yang adult tu kita akan ambil the longer leg ke macam mana?
Now you just cross the leg, either one, either you put on the top or the inferior, it should be okay. By doing that, in case of the leg or the hip is adducted, to start with adducted deformity or adducted contracture, the pelvis will be tilted. Okay, so you want to square the pelvis, you cross the other leg. When you cross the other leg, and then the pelvis will become straight because the movement now at the pelvis rather than at the hip in case of fixed adduction deformity of the hip. Okay, so if let's say patient come to you with fixed abduction, you need to do the opposite also. Just now in this case, fixed adduction, you need to cross the leg. If fixed abduction, what you need to do is you need to further abduct the hip so that the pelvis later on akan appear normal or will normalize. So in this case, if patient have fixed adduction deformity, so the leg appear, the affected leg appear shorter. Okay, if patient have fixed abduction, because in abduction, the appearance, the leg appeared longer. So how to square the pelvis? In fixed adduction, we further adduct or we cross the leg. Okay, we further adduct. In case of fixed abduction of the hip, we further abduct of both leg, so the pelvis later on will square, and only after that you measure. Understand? Get it or not?
Yes, Prof.
Okay, good.
Prof,
Yes.
how do we abduct both legs for the fixed hip adduction?
Because fixed abduction means patient come to you with already one side is abducted. So you abduct the normal side. Okay. Same thing here. If the, let's say, right side is adducted, so you further adduct the normal side. You cannot further adduct the affected side. You adduct the opposite side. So only that you will get the pelvis is square. So same thing in abduction. Let's say patient have fixed abduction of the hip on the right side, so you further abduct the left side, the opposite side. After you do that, you will get the pelvic to be square or at the same level.
So doctor, meaning that to spread the leg, is it to
Yes.
spread the leg? Okay.
Yes.
Okay.
Yes,
Thank
you are right. Okay, good. Okay, so if you use the what we call the block test, so you need to keep or you need to put the patient in, or you ask patient to stand on the block, and you need to increase the level of the block until your assist is at the same level while standing. Okay, so like this. Okay, so this is the other measure. So this is sorry, this one we discuss again later when while the measurement through the using the block test. So just now once you square the pelvis, so only you put your tape measurement from assist to medial malleolus. Okay, so you measure the normal side and you measure the affected side. So let's say from this point to this point minus this point to this point. So you will get, okay, now a true length. Let's say right side is affected, you start with normal side. The limb length discrepancy of the right leg is 2 centimeter shortening, for example. So you will get the whole level of shortening, okay, of the lower limb. So you report patient have right lower limb length discrepancy of 2 centimeter. All right. So now you are doing the true length. You want to know where is the shortening, where is 2 centimeter shortening come from? Okay. So it could be from the tibia, or it could be from the shaft of the femur, and it could be from Whereas that can contribute to 2 centimeter shortening, for example. One from the tibia, problem with the tibia, or it could be problem with the femur, or it could be problem where? At the
femoral height or above trochanter level.
above trochanter level, right? It could be above the trochanter level. Okay, so now you notice that we measure from the axis to media malleolus. Okay, and then you measure for the media joint, for the media joint line, for the tibia component, you measure from media joint line to your media malleolus. And for the femoral component, from media malleolus to your axis, kan? Your axis. Why not you measure from media malleolus to a lateral malleolus? Why do we measure from axis to media malleolus? Why not from axis to lateral malleolus? You understand my question?
Yes. Q angle.
Q angle, no?
Hmm.
No. So because when you measure segmentally, okay, you measure from media joint line to media malleolus as a femoral tibia component, greater trochanter to a media joint line, okay, for a femoral component. Why not you measure from axis to your lateral malleolus? It's easier, right? Why not?
Anatomy of the bone.
Now, what is the anatomy of the bone? Sure, that is the anatomy of the bone. How do you explain?
Kalau
Nanti
sama tu kan.
Again?
if anatomical axis.
No, it's not talking about axis here. We're talking about measurement. Okay, so if you measure from medial malleolus to lateral malleolus, and you measure from lateral malleolus to lateral joint line, much easier, right? Because one straight here, right? But the thing that this is not a standard way of measurement, because if you put from axis to lateral malleolus to lateral knee joint line, okay, or from the lateral part, basically you are putting the landmark from two different bone. Lateral joint line is your tibia, but lateral malleolus is your fibula, right? So two different bone, right? So later on you cannot really know whether if you put from lateral joint line to lateral malleolus, it's not really represent the tibia bone. Understand? So that's why we put from media malleolus to axis, media malleolus to axis to media knee joint line to represent the femoral component and the tibia component. Okay, of course, for a Bryant triangle, we want to locate whether the pathology is above the trochanter or not. Okay, are you clear? All right, so this is your media joint line. Now, to determine the Bryant triangle, Okay, so because Bryant triangle is to indicate or to look for any pathology that can lead to the limnar discrepancy as well. Okay, so Bryant triangle basically you locate from your axis greater trochanter, right? Okay, so basically the line by right, the line is up to here lah, greater trochanter here. Okay, not ni fossa, ni kat sini sikit. From here to here. Okay, 2 point that connect antara axis and greater trochanter. And then second line is an imaginary line that is perpendicular to the axis here. You draw a imaginary line that perpendicular to your axis. And then how to make a triangle here? How to form a triangle? So this is, you connect between this line to this line and they become 90 degrees. So they become a triangle. So basically, the height that what we interested is the line C here. Are you clear, Nak? Are you clear? Understand or not understand?
Yes.
Okay, so what we interested to know is the height here. How much is the height here? And you compare on the normal side and the affected side. So let's say now if you go back, okay, you measure the tibia component. Okay, tibia component, let's say you have X value, sorry, and you measure from medial joint line to your assist is Y value. So is X value and Y value is symmetrical both sides, but your first measurement just now from here you have 2 centimeter limb line discrepancy. So now you know that tibia has sequel, femoral is shorter because from here to here is shorter. What you want to determine, where is the shortening? Is it at the shaft or is it above trochanter? So that's why you do your Bryant triangle here. So if your Bryant triangle is not equal, and then you need to think the pathology above the trochanter area. If your shaft is not equal, you need to think what are the possible etiology that involve the shaft. For example, like malunion. Okay. So now, if Bryant triangle is not equal, what are the possibility? What are the possible underlying problem? Okay. So like say here, so A is may represent problem over the tibia like malunion. B may represent femoral shaft problem. Okay. Okay, and then C is your Bryant triangle. So what are the possible cause of problem with unequal Bryant triangle?
Epiphyseal injury.
Which epiphyseal injury? Okay, let's say you measure limb line discrepancy 2 centimeter. The tibia is normal, both sides equal. Femoral shaft is equal, but the Bryant triangle is not equal. Let's say one side is 5 centimeter, the affected side is 3 centimeter. So now you want to know what are the possible cause that cause shortening at the Bryant triangle. So what can be the possible cause or etiology or underlying problem?
Dislocation of the hip.
Dislocation.
Okay, good. Hip dislocation. What else?
Coxavara.
Koksawara. Okay, very good. What else?
The fracture of the head of the femur.
Okay, fracture neck as well as yang displaced fracture neck and severe fracture of the head of the femur. Okay, what else?
Malunion. Malunion of
Where?
the probably at the intratrochanteric.
Basically intratrochanteric because you measure at the greater trochanter, probably is not really affected lah kan. So above trochanter lagi, what are the other possible underlying greater trochanter and above pathology? What else?
Acetabulum destruction.
Okay, so this one we call a protrusio-acetabuli. You can have or secondary to, let's say, central dislocation. Protrusio means is ruptured. Okay, protrusio lubang. So the head going inside the acetabulum. Possible. What else?
Avascular necrosis.
Avascular necrosis of femoral head that lead to severe collapse of the femoral head. All right. So Kotsawara, okay. You can have severe loss of articular surface for secondary to OA ataupun because of secondary infection before, like septic arthritis. Okay, septic arthritis I showed you earlier in case of neonatal septic arthritis. Okay, or like DDH, developmental dysplasia of the hip, DDH in pediatric, or probably a hip dislocation. And of course, if you have what we call Protrusio acetabular means that the central hip dislocation. This one is posterior hip dislocation. Central hip and the femoral hip goes inside the acetabular. You may have a problem that your Bryant triangle also shorter. Okay. So if you have this positive Bryant triangle unequal, what do you expect the type of gait that patient may have as compared to, let's say you have malunion of tibia or femur? Is it similar gait or not?
Trendelenburg gait.
Trendelenburg gait. Okay. Why patient have Trendelenburg gait?
Weak abductor muscle.
Okay, because the abductor muscle is supposed to be at this point. Now, because the level of greater retrocenter is more proximal, so that can lead to weakness of abductor muscle. So, in this case, patient will come to you most likely having a positive Trendelenburg test, and also patient have a Trendelenburg gait. Whereas in case of fracture femur or fracture tibia, in case of malunion, patient will come to you with short limb gait rather than Trendelenburg gait. All right. So I hope you can see from any YouTube the difference between short limb gait and Trendelenburg. I don't have in my collection here. Okay, are you clear? Any question here? No. Huh? All right. So like in this case, how you describe this X-ray? What happened to this X-ray or this patient? Come, somebody describe this pelvic X-ray. Year 4 lah, year 4. Syazwani lah, sebut nama lah. Or Jazlan or Aisyah. My mentee tu. Come, describe. How do you describe this pelvic X-ray? It must be systematic. Wih, dah seru nama pun tak jawab juga. Jazlan?
Okay, okay, this is the X-ray of the pelvic
Yes,
joint.
that's what I told you. Okay. What's the finding?
Okay, so there is a loss of acetabular, loss of
Itu bahasa apa you pakai ni?
okay, there is loss of the surface of the femoral head is irregular. And there is increasing density in the femoral head.
Density. Are you sure? Okay, next. Aisyah. Aisyah ada tak? Ada tadi kan? Aisyah, komen. Aisyah tak nak komen? Jaswani?
The bone, loss of continuity of the bone line tu.
Alright, can you see my cursor or not?
Yeah.
Oh, so okay. First, when you describe the pelvic X-ray, you must be systematic. You start with this one. We call what line is this?
Shenton line.
Your Shenton line. So you say that Shenton line is the line you draw at the medial aspect of the femoral neck, go inferior to the superior pubic rama. It must be a smooth curved line here. What you see here, if you follow this, and then the break, they're not a smooth one. Okay. So first you comment there is a broken or distortion of the Shenton's line. All right. So and then if you see here, the pelvic X-ray is symmetrical because you can see that your obturator foramen is almost equal in size. Dia tak ada macam separate. Okay. And you see here, either you see at the lesser trochanter level or you see at the greater trochanter level, this is not at the same level. This one is migrated proximally. That's why your Shenton line is broken. Okay? Can you appreciate that? And you see here, it's supposed to be here. Now you migrated proximal. Okay, and if you see here, you can see a very smooth articular surface of femoral head. But over here, you see that femoral head is smaller, and you can't see a normal congruent. Okay, smaller and incongruent of the femoral head. And you see that this is your acetabular is well formed, and you see it's irregular and more dense over here. Okay, you see the femoral head is smooth, but you see there's a lucency. It's not dense, Jaslan. It's rather lucency here. You see macam ada cystic here. Alright, cystic here. Alright, and if you see the quality of the bone, compare here and here. Okay, this is good light, more osteopenic. Alright, so this Shantan line is broken, loss of spherical femoral head, and the irregular surface of the acetabular, the cystic changes of the femoral head, and proximal migration of the femoral head here. Okay, that's the finding. Okay, so what is the most likely diagnosis here? Yes, the most likely diagnosis in this case.
Arthritis.
Arthritis is very broad. What type of arthritis? Osteoarthritis?
Sciatic arthritis.
Other offer? Other option or other possibility?
Central hip dislocation.
No, central hip, you see that, okay, you see this line, what we call the line of, to show that the acetabular is intact. So there's no protrusion of the head above or beyond this acetabular line. So this one we call ilioischial line. This one from here, ilioinguinal line, that represent the anterior column. This line represent the posterior column, and this one is intact also. So you're not worried about this acetabular. So there's the head is not going beyond this, but rather go more proximally with all these changes. All right. So what could be the underlying problem in this patient or diagnosis?
Acetabular dysplasia.
Now find the year lah. Diagnosis. Can you offer me diagnosis? If we have this patient during your pro exam, for sure we will bring this patient, and you should know this. Kan? Siapa ada situ? Aklan. Siapa lagi ada? Hidayah ada.
AVN, Prof? Hip AVN.
So this look like it was clear necrosis of femoral head. You know, the cystic changes, the collapse, okay? And on top of that, they also have a arthritis, osteoarthritis changes. So you notice that it's significant loss of bone, okay, and lead to migration, and because of that, you have shortening here, okay? So if this one clinically ankylosed, so patient may have limited range of motion. If not, patient may have a positive triangular, positive Bryant triangle, unequal in length. Okay, you can have a true length discrepancy. Okay, if you do a triangular test, it could be positive here in this patient. Okay, and if it's also associated with fixed flexion deformity, they're fixed in a flexion of the hip, you may also have a positive Thomas test. Okay, so for year 4 later we will discuss again the detail about the hip examination. All right, you have a Thomas test, triangular test. So understand? Any questions? So you see this changes, the cystic changes, loss of articular surface with erosion and what we call sclerosis of the acetabular. This may indicate of AVN with osteoarthritis changes rather than DDH. Okay. Of course, your differential diagnosis you can offer is septic arthritis, chronic septic arthritis that lead to bone destruction of the bone and cartilage. Okay. But cystic changes more suggestive of AVN. Okay, understand? All right.
Prof, I have a question. Regarding, let's say we're talking about hip osteoarthritis, do we really like to expect like what we see in the knee osteoarthritis, like the osteophytes, subchondrosis and sclerosis?
Osteophyte, not really. So what you expect to see in the hip osteoarthritis, basically joint space. You reduce joint space with sclerosis, and probably like this, patient also have collapse of the or irregular femoral head. Okay, so osteophyte, yes or no, you may see the yes or no. Okay, so the joint of the knee is clear. You can see reduced joint space on the medial compartment, lateral compartment. But over here, you still can comment that the joint space is reduced. Depend on the stage. In this case, joint space not only reduced but also distract, and it's not normal, smooth, congruent joint line. Okay. So you probably can see the osteophyte at the edge of the sternum. All right. So depend on the stage of osteoarthritis. You may or you may not see the changes, just like the knee OA. Okay.
Thank you.
Doctor,
Yes.
in this case, is it the clinically ankylosed can cause the fixed flexion deformity?
Possible. Okay. If patient end up with ankylosed knee, it can end up with either fixed adduction plus fixed flexion deformity, or either one. Depend on how the hip is ankylosed. Okay. Especially ankylosis occur following infection, either tuberculosis infection or septic arthritis. Okay. Uh, Osteoarthritis secondary to AVN usually not really end up with ankylosis, but rather come with hip pain, with some shortening. Ankylosis usually secondary from infection like TB usually. Okay, so if ankylosed, usually either feet flexion, meaning inflection deformity, or a combination, feet flexion plus fixed adduction. Okay. Right. So now, if you use a standing block, how do you measure the limb length discrepancy? So I said just now, you make sure that the assist is equal, and then you ask patient to stand on the block. Okay, like in this case, go back to first case, you see that patient have abnormalities of this right lower limb. Relatively, you see here and here is proportionate, but you see here and here is not proportionate. This one is bigger, okay, and you see that if you see close up view, you can see the abnormalities, okay, and you see how the patient stand. He need to flex the longer leg, or what he can do is he can stand in tiptoeing, and over here you see that the level of the shoulder is dropped here, and then the abnormal crease, and patient looks having scoliosis, tilted kan, or deviate. But of course you need to see whether it's a true scoliosis or not, right? So if you measure using a tape measure from axis to medial malleolus, you may not get an accurate measurement. Why? One, because you may not able to palpate the medial malleolus on the abnormal side, just like the normal side, because the leg is hypertrophic. You can't really appreciate where is the bone. Second thing is, when you do a tape measurement, you just measure from assist to medial malleolus. But you see here, in this patient have pathology also beyond distal to it. It could be at the fat of the calcaneum and foot also. Like your friend mentioned just now, is more functional here. So if you measure using a medial measuring tape, you may miss the abnormalities distal to medial malleolus. Okay, so if you measure through the blood test, like in this case, you see, if patient without blood test, you see the pelvic is tilted, patient stand in leaning to one side, shoulder is dropped. So you put the patient stand on the block, okay, and this block represent the thickness. So how many blocks here? the 7 block thickness of 1 centimeter. So this patient requires 7 centimeter thickness of block in order to have a equal pelvis. So the pelvis doesn't drop anymore. Okay, and then the shoulder is equal. Okay, so how do we know how much is shortening? Is we make sure that after this, the pelvis is normalized, and we measure the thickness of the block. So the thickness of the block. If the patient require 7 block of 1 centimeter thickness, meaning that patient have 7 centimeter shortening. Okay, so in our clinic we have the block. The block usually about 1 centimeter or 0.5 centimeter. So we increase in the height until we get the pelvis is equal. So the length or the limb length discrepancy we measure here. Okay, so this is more functional because you take into consideration the pathology beyond or below the medial malleolus. So my question earlier, which one is more accurate? You measure through tape measure or blood test? Okay, you said just so is blood test supposed to be better clinically, right? Because they can cover the pathology distal to medial malleolus. Okay, are you clear about the measurement, clinical measurement using measuring tape and also the blood test?
Yeah.
Doctor,
Yes.
after we done the block test, should we measure the tibia and femur and also the supratentorial?
Okay, if you want to know the segmental length, yes, of course. You can do using a measurement using a tape again. But at least now you know you have about 7 centimeters, and the problem probably is not only bone. You need to take into consideration the soft tissue component also. Okay, so tape measurement is just taking into consideration the bony pathology only. Okay, so this one is more functional because if you plan later on for treatment, so you know, okay, this patient have 7 centimeter shortening, including the bone and soft tissue. Okay, right. Any other question? Okay, we move on. So, in summary now, what we need to do is we get a proper history. We want to know whether patient is having this since birth or acquired. Okay, and then we do a physical examination, look how the patient stand, look at the shoulder level, any presence of this scoliosis or not, look at the pelvic obliquity. Okay, either patient stand with tiptoeing or flexion of the longer leg. Okay, and then from that we can do blood test or whatever. Okay, we look at the gait. Okay, and then we assess scoliosis when we ask patient to. If patient sit, the scoliosis remain, it means that it could be a structural rather than postural. Or the other test is what we call a Adam test. We ask patient to bend forward in a rukuk position, 90-degree bend forward, and then we see whether this scoliosis remain or disappear. If the scoliosis disappear on sitting and or bending forward, that indicate is just a postural, not a bony problem. Postural means that maybe because of limb length discrepancy. Okay. And then we put patient on supine position, screen with a Galeazzi test, and then proceed with apparent and true length measurement. Okay. And then, of course, complete with range of motion of the joint. All right, are we clear now? So from the history and physical examination, we can have an idea. So whether this patient have true or apparent limb length discrepancy, and then we should know what to plan to further confirm the diagnosis, in which we need to do radiological investigation. Okay, so radiological investigation we have so many options. start with plain radiograph to rule out other underlying pathology, okay, or autoangiogram, teleo, CT scanogram. So this is will give you a different parameters and different accuracy, okay. Like this autogram, they have one long film, and they have three different bin center at the different joint, okay, center at the hip, knee, and the joint. All right. This is your teleo. We have long film also here, center at the lower limb, and then we can measure. Okay, we can measure where is the shortening. Pelvic is tilted or not, from here to here for a femoral component, from here to here for tibia component. Okay. CT scanogram. Okay, of course we can do CT scan before we do the detail, and this one also we can measure. All right, by doing this. Okay, now a little bit on, if let's say a pediatric come to you, pediatric patient come to you with limb discrepancy, especially following physis injury. If because of bone or let's say malunion is different. Let's say patient come to you with physis injury following, let's say, trauma or infection. If trauma, let's say patient have Salter Harris type 5. Type 5 meaning that the entire physis is injured. Okay, the difference between limb discrepancy in pediatric and adult, because pediatric is still growing. So we are interested not only the current limb discrepancy, but we want to know at maturity how much the limb discrepancy will be end up if we don't do anything. Whereas in adult, if you have limb discrepancy, they will remain whether this year or next year in next 5 years. That's because the patient is not growing anymore. But in pediatric, it's important, especially that involve the growth plate. Okay, let's say patient had trauma or patient had infection to the knee joint at age of 10 years old. So we want to know at maturity, when patient stop growing, how much limb discrepancy if you don't do anything, right? So by knowing how much growth contributed by each growth plate, so we can estimate, we can predict how much the true limb discrepancy at maturity. Okay, are you clear why we need to know that? Okay, so basically most of the growth occur around the knee region. Okay, the knee region, and mostly over the distal femur. Okay, it's around 9 millimeter a year. Okay, followed by proximal femur, distal tibia, and proximal tibia, distal tibia, and proximal femur. Okay, this is the roughly how much length occur a year. Of course, the different whether this is at the growth spurt or later, but it's the in general. Okay, so you can imagine, let's say patient had trauma to the distal femoral physis, complete damage, let's say due to Salter Harris 5 or severe septic arthritis. So about 9 millimeter to 1 centimeter lah, loss of length per year. Okay, so from this we can predict lah. Let's say patient had problem at age of 10 in boy. Okay, so boy, we know that patient will stop growing around 16 to 17. So if patient had injury at age of 10, so they have another 6 to 7 years remaining years for the bone to grow. So if patient had complete damage here, so if you don't do anything, they will lose 9 to 10 millimeter times 6 years. So around 6 centimeters patient will have a limb discrepancy as compared to normal side. Okay, but if patient in adult, of course there's no more physis, patient have a problem with the femur, like say malunion, they will remain. So that's different. Why the limb discrepancy in pediatric, especially the involved the physis, is more important for us. Okay, are you clear? All right. So there's ways how we can predict the growth. Okay, so you don't have to know very detail, but I just mentioned a few names here. One is what we call arithmetic. Arithmetic is basically the name we call a rule of thumb. Just now, rule of thumb, let's say the distal femur have about 9 millimeter a year growth, proximal tibia about 6 millimeter growth. This is arithmetic or rule of thumb, number one. So this is first method using the arithmetic. Second method, they have what we call following the Green and Anderson. Okay, mostly straight chart, and the more complicated and the latest what we call a multiplier. So this is the way how we predict the growth of the bone in pediatric. Okay, you don't have to know in detail about this. Okay, so let's say we ask you and you're able to answer this, meaning that we want to give you a better mark. All right. So now we just touch a little bit on principle of management. So when patient come to you with limb length discrepancy, we want to know the range, what we should do. Okay. So if limb length discrepancy is around 2 centimeter or less, usually there's no treatment is required. It will not cause significant changes or effect to other joint. Okay. 2 to 6 centimeter or more than 2, you will have to treat. Because otherwise they can cause damage or damage to the other joint like hip joint or secondary scoliosis. Okay, so in general, if 2 to 6 centimeter, what do we have? Either we can do epiphyseal disease. Epiphyseal disease means that we slow the growth of the normal side. Okay, shoelace is a bit too much here. I think it's not right here. Shoelace is strong here. Okay, sorry for this. So epiphyseal disease for the normal side. Okay, or what we can do is we can do for longer than that. The option either we lengthen the shorter side, or we can shorten the longer side. We can lengthen the shorter side, or we can shorten the longer side. But of course, how do we decide this? It depends on the patient, whether the patient is enough tall or not, or if patient is shorter or is short, and then we usually we proceed with lengthening rather than shortening. In case of shortening is very much more than 20 centimeter, especially in congenital problem. If you remember that I show you the earlier picture of fibula hemimelia, so that one is not reconstructable, so it's not salvageable, so that patient may require from amputation and we give prosthesis. Okay, so this is basically the general guideline. Forget about the shoe lift, it's not indicated here. Either you do epiphyseal disease, lengthening, or shortening to the other side. Okay. Okay, shoe lift usually for about less than 2 centimeter if you want to make sure that the gait is normal, but it's not really have a big effect. Kalau you tengok patient pakai shoe lift about 7 centimeter, it's not right lah. Okay, you won't give a good result. Okay, this one we call epiphyseal disease. Epiphysis is epiphysis. Disease means we stop the growth. Okay, so like this is the example that we put the screw across the physis. So if we do this, meaning that we aim for a permanent stop of growth. Okay. Whereas a temporary, either you use this one we call a stapler, or the other one we call a 8 plate. The plate that have number 8, and then we put a screw across proximal and distal to it. So that's why it can be temporary. Temporary means that once we remove the screw and the plate, the patient bone can grow again. So in general, indication for permanent is patient near maturity. So meaning that if patient is a boy around 14, in girl around 13, 12, that near to maturity, because female they start lengthening or start growing around 14 to 16. So for temporary, this indicated when patient is younger age group, because Once we remove, they can cause rebound of growth. So we can repeat. Okay. Okay. In case of shortening due to bone loss or due to malunion, we can do lengthening. So you know we have lengthening either using ring like Elizarov with bone transport here, or we can use as stenofisator limb reconstruction system here, and then we lengthen the bone. Okay, so either we stop the growth, we lengthen, or we shorten the longer side. So that's an option for the treatment. Okay, all right. I think that's about all that I want to share. Okay, any question?
Prof,
Yes.
nak tanya, contoh kalau patient tu dia after fracture ke ataupun dislocation yang akan menyebabkan limb length discrepancy,
Okay.
maksudnya the doctors will advise the patient based on the length of the discrepancy ke?
Now, when patient come to you, of course, you're talking about pediatric or you're talking about adult. If adult, I said just now, adult, it's not really critical like pediatric because we can predict. There's no more growth. Let's say patient come you is the patient is adult, patient have malunion of the femur, or patient have open fracture of the femur with bone loss. Now patient end up about 5 centimeter, 5 centimeter shortening. So what is your next option? So I said just now, next option 5 centimeter and above, you can lengthen the shorter side or you can longer the shorter side. You can lengthen the shorter side or you can shorter the longer side. Meaning that if patient already enough height, already tall, so patient want to have equal limb immediately. So what we can do is we cut the normal side about 5 centimeter or so that at the end they equal in length. So this is usually in case of limb length discrepancy that have no union problem. But if patient have no malunion with bone loss 5 centimeter, so no other than you need to lengthen. You need to use either bone graft, Elizarov ataupun external visitor just now lah. So let's say this is a pediatric umur dia 10. Now patient have problem with septic arthritis of the right knee lead to damage of the distal femoral physis. So you know that now patient have at age of 10 that once developed and patient come to you at age of 12, they have 2 centimeter shortening. So if this is a boy, 12 years old, patient have 2 centimeter limb length discrepancy. So you know that patient have another 12 campur around 3 to 4 years, 16 saja. So 4 to 5 years to stop growing. Dia akan stop around 16, 17. So you know that patient, if you don't do anything, patient will end up with about 4 to 5 centimeter shortening at maturity. Okay, now what should you do? Okay, what should you do? So you have to see patient as a whole. If patient already have enough height, good height, so you have to discuss. In general, either you can maintain the shoulder side 5 centimeter using the Elizarov, okay, atau you can do epiphyseal disease on the normal side. You can put the plate just now atau screw so that the affected side won't grow anymore. So the affected side akan compensate. Alright, faham? Are you clear? Alright. Okay, any other question?
Prof, I have a question.
Yes.
Two questions actually. First and foremost, with regards to the option to lengthen the limb, just now you mentioned about Elizarov and also external fixator. May I ask, is there any bone graft role or perhaps any usage of bone graft in such cases of LLD? My second question would be that for more than 20 centimeter, you mentioned of prosthesis. Is it any difference from the one that is used in like amputation cases, Prof?
Oh, okay. So I answer your second question first. So it depend. Okay, it depend. usually that patient who come to you with severe congenital abnormalities, like I show you just now, which is we cannot reconstruct the lower limb. Okay, so there's two ways. Okay, if possible, some of the patient they don't want to have amputation. Okay, so but the problem is if we keep the congenitally foot or lower limb like that, so not much option of prosthesis available. Understand or not? So there must be a custom made prosthesis to fix the remaining abnormal lower limb to the prosthesis. Okay, so majority what we need to do is we need to do amputation, remove the abnormal lower limb, and then give a prosthesis, normal prosthesis like adaptation. But the problem is, since this patient is growing, so you need to change the prosthesis many times according to patient growth until patient start growing. All right, understand? So back to your first question just now, whether the patient require bone graft or not to treat limb-line discrepancy. It depends on what are the underlying problem. Is limb-line discrepancy because of bone loss? Then you want to achieve the union, okay, and then you may need bone graft here, okay. But let's say limb-line discrepancy because of malunion, okay. So malunion you don't need bone graft, you just need lengthening procedure, bone transport only. So that one can be done either Elizarov ataupun external fixator just now. So you have to see what are the underlying problem that lead to limb-line discrepancy lah. Okay.
Alright,
Alright.
thank you, bro.
Okay, any other question?
Prof nak tanya, contohnya kalau macam dia ada shortening dekat right leg kan, so dia ada option sama ada dia nak lengthen the shorter leg ataupun dia nak shorten the normal leg, betul tak? So kalau macam tu, selalunya patient dia akan pilih yang mana satu sebab the problem is on the right leg. Tapi
that's the issue, right? Sometimes because patient say that you already have pathology on one side, why you want to cause the injury to the normal side? Okay, so you have to discuss patient with patient whether what is the preference of the patient. So the indication is not or rigid. Is you must see patient as a whole. Okay, so if the patient, let's say the patient is enough height, okay, and patient have limb-line discrepancy about let's say 3-4 centimeter, and the patient said that I don't want a longer procedure, longer treatment. You remember that when you decide to lengthen the shorter bone using Elizarov or using the limb-line LRS or what we call external fixator, they will take some time. Some time means that for 5 centimeter probably they require about 1 year roughly the process of the treatment. So and then because you put the external fixator or the Elizarov for quite some duration of period of time, so there are the complication like infection, pin tract infection, everything, right? Second, there's a possibility that your lengthening will end up with non-union or delayed union because you need to cut the bone and you need to transport. Okay, so some of the patients don't want to take that risk because they don't want to have longer external fixator, and if this patient have a quite adequate height and he want immediate effect, so of course he need to accept that they have to have injury to the normal side. So now one side is already shortened because of disease, and now he need to suffer temporary by cutting the normal side, but they will get the immediate effect. Okay, understand? But if the patient is short, so you can offer, okay, let we cut the normal side because it's really short. And when it's really short, they may have problem later on. Maybe they want to press the switch or the button dekat lift ke apa ke. So the decision is depend patient on patient. Okay.
Okay, Prof. Thank you.
Right. So any other question?
Prof,
Yes.
Just now you mentioned about temporary epiphysiodesis. When we remove, it can cause rebound of growth. Can you repeat about that? I'm not so clear about that.
Okay, so of course, when we said temporary, means that we don't aim for a permanent. So the indication is for the patient is longer duration of growth, meaning that younger patient. So if patient come to you 14 years old and 10 years old, of course, this temporary we do for a patient younger, 10 years old. Okay, so remember, epiphyseal disease, we stop the growth of the normal side. Okay, the normal side. If we aim for permanent, we put the screw, so the physis is not growing anymore. But temporary means that we put the screw, we do cross the physis. We put proximal and distal, meaning that we put the screw at the metaphysis and we put the screw at the epiphysis. So the physis is spared. We just hold the growth by putting the screw in between that. So if we remove this plate and screw that hold the physis to grow, so there's a possibility that they will grow again, and then there's a possibility that they grow even more than or longer. We got a rebound. Okay, so that's why this procedure we can repeat. Let's say you start at age of 10 and you aim to put for 2 years, and you want to aim for 2 centimeter equalization. So after 2 years, you remove. So if we start at 10 years old, now 12 years old, from limb-line discrepancy of 2 centimeter, you manage to equalize, because from your prediction just now, the distal femur will contribute about 9 millimeter to 1 centimeter a year. So when you remove at age of 12, there's a possibility that the normal side, that after you remove the screw or the stapler just now, they will grow longer than the normal side, the affected side. So you can always repeat. So you see the pattern, you can repeat. Okay, that's what we call a temporary. But if you decide to put permanent, meaning that you damage, you already destroy the physis. So there's no chance of regrow or rebound again. So understand?
Understand. Thank you, Prof.
Okay. So any other question?
Prof, nak tanya sikit regarding the clinical examination for true and apparent length.
Okay.
So during the stage for short cases, we have to do both lah, the apparent length and also the true length, and present.
Yeah, sure. Because the requirement for you to do a true length, you must do the apparent length first. Okay, you cannot go straight away and measure the true length, because apparent length, it could be not a true limb-line discrepancy. It just appeared. It just appeared shorter or longer. So you should do a apparent length first, meaning that you just measure without need to square the pelvis. Whatever position of the limbs, you just measure. Whereas when you want to do a true length, you need to make sure the pelvis is equal. Either you need to cross the leg or you need to further abduct. You need to do that. So to answer your question, yes, you need to do apparent length first, followed by a true length. Okay?
Alright, thank you, Prof.
Okay, any other question? Okay, if there's no more question, I think we should stop here. So thank you very much. Hopefully, if there's no any in future we have some more teaching, I will share with you lah. Okay, is it okay year 4 and year 5 combined teaching?
Okay.
Okay.
Okay pun macam dalam tekak je okay, macam tak setuju. Never mind, you
Prof?
don't see each other kan?
Sorry,
Yes.
Prof. I have 2 questions. Sorry, my mic's problem. Hello?
Yes. Yes.
Okay. I have 2 questions. In regards of the examination for the apparent length and true length, if there is any discrepancy between these 2 measurements, should we always prioritize the true length? For example, we calculate the apparent length, we have like shortening like 2 centimeter, but true length measurement showing more or less of that number. So how we approach that? Yeah. And then the second question regarding the square the pelvis, if the patients have no significant or not presented with fixed abduction or adduction, is it adequate if we square the pelvis parallel to the back? So that's all.
Okay, first of all, the most important thing is you must make sure that you identify a correct bony landmark and you mark it properly and to reduce the risk of error in measurement. Okay, so be careful if your patient is obese. Alright, so we know that if you have difficulty to find a proper landmark, that one will affect you punya measurement later on. So what happen if you have discrepancy in lower lip, apparent and true line? Which one is more accurate? Of course, the true line lah. Okay, because apparent line by definition, you don't do any maneuver to correct the malposition. Okay, you may get about maybe 2 centimeter, but the true length actually jadi 3 or 4. So we take the true length. Okay. Second, yes, now you see that we're going to square the pelvis. Yes, sometimes the pelvis is not really bad. It's not equal, but you still need to demonstrate to us that the pelvis is equal. So how do you do that? So you already mark the assist both side, medial, then left and right. So there's many ways. Some the classical orthodox ways you put your forearm and to connect to the two things, the 2 point, which is for me is not advisable lah. Okay, so the easier way is you just use your tendon hammer and you just put horizontally and connect that 2 point though, and you see whether this is true equal, I mean that there's no tilted anymore or not. So you must demonstrate to us that these two axes is at the same level before you start measure. So you understand what I mentioned just now?
Yes. Okay, thank you.
So is you still need to demonstrate before you do a true line that this assist is equal in the position. Okay.
Oh, all right. And then for the fixed adduction and adduction, I just want to clarify, is it the same like the concept we mirror the deformity?
Yes, you mirror the deformity. Yeah, you are right. So meaning that fixed adduction is already the adduct inside kan. So that's why you need to cross, you need to mirror it. Okay.
Okay, thank you, Prof.
Okay, so any more question? Okay, if not, I think thank you very much. I think we stop now. Thank you very much. Hope for the best for final year. When's your exam? From I already told you.
26 October.
26 October until
Early November, 1 or 2 November, I think.
Okay, so still got time lah. Okay. Alright. So what you need to do, I think I suggest to you, and now we at Orthopaedic, we have online teaching with year 4 kan. So you may approach the lecturer if they have teaching online like this, whether they can share with you or not, like what I'm doing today lah. Okay, especially if you have free time and you can join lah. Okay, so why not? Especially kalau dia buat after office hour ataupun is that you can accommodate with you kan. Okay.
Okay, Prof.
Alright. Okay, bye. Thanks. Okay, Assalamualaikum.
Thank you, Prof.
Okay, bye.
Thank you, Prof. Kita nak check.
Alright, bye.
Thank you, Prof.
Bye.